right. I hope everybody had a good weekend. This is for Monday, July 6th. So this would be day 4. You also have an MRE number 2, along with your homework, which is due. So the MRE is actually due today, July 6th, Monday, by midnight. And then your homework then for this, that goes along with this section, is homework number 4, Desjardins. That's your workbook, pages 86 through 93. And then you also have a true and false worksheet. And make sure that you change those false statements to a true statement then. So tell me, why is it false? So basically change it to a true statement. And that would be due then on Thursday. Both of those assignments, number 4 and number 5, will be due Thursday, July 9th. So again, hope you all had a good 4th. It was great to see everybody last Thursday. And today we're going to be talking about blood and some of the different diseases associated with blood. So this is a little bit of a long lecture. I apologize, but we need to stay on track because really this class isn't that many. Doesn't really meet that many times, so I just kind of have to hang in there. Now I know some of this stuff you guys have talked about in A&P also, so hopefully some of it will be a little bit of a review. So blood is basically identified as a highly specialized cells with called formed elements. Okay, so make sure that you know what are the formed elements. So you'll have multiple choice questions on, like, which constitutes the formed elements. Okay, and so these formed elements then are suspended or held in the plasma. Okay, blood is our primary transportation of fluid for the body and helps protect from foreign invaders. Some of those formed elements do, as in the white blood cells. So the 3 formed elements that you need to be able to identify. So plasma then is what it's suspended in. So you have red blood cells, white blood cells, and platelets. Okay, so what red blood cells, you might a lot of times it's just going to be abbreviated RBCs, so just kind of get used to that. Otherwise known as erythrocytes. Okay, ERY. Generally ERYTH, I believe. All those letters usually have to do with blood or red. And cytes meaning cells. Leuco then meaning white. So leukocytes then are your white blood cells, and then your platelets are your thrombocytes. So when you think like a thrombus, you think of clots. Okay, so platelets really aren't true cells. They're basically fragments that are produced by the megakaryocytes. So they lack a nucleus and they are irregularly shaped. And they are essential for your blood clotting. Okay, so you can kind of see in the little picture there how the white blood cells, the red blood cells, and then these platelets then are like fragments. Okay, so that's what makes up your formed elements. So again, different functions of the blood then is to help transport oxygen to the tissue cells and CO2 to the lungs, helps transport nutrient and waste products, transports the processed molecules from one body part to another. For example, like lactic acid is carried by the blood to the liver, where then it's converted to glucose. Also helps transport our hormones and enzymes, regulate pH and osmosis. So we're able to actually measure the pH of the blood, but then the different constituents can help regulate the pH, helps maintain our body temperature, helps protect against foreign substance, with being mainly the white cells, and then again the platelets are what helps form our clots. So this little slide here is just a little bit of a history. I'm not going to test you on this. It's just kind of little trivia kind of stuff. So you can go ahead and kind of read through that yourself. I'm not going to read it out loud to you. You're capable of doing that because, again, I am not going to be testing you on this. All right, so the average amount of blood in a body is about, for whole blood, is about 4 to 6 liters, okay, which kind of correlates into your liters per minute for your cardiac output. Okay, so that kind of makes sense, right? 4 to 6 liters, it's how much blood is in our body, and our heart is able to pump 4 to 6 liters per minute. It makes up about 7 to 9% of our total body weight, and the amount is kind of broken down. We're about 2.6 liters, so a little bit more than half is your plasma, and then the rest of it, about 2.5, 2.4, just a little under. The 45% then is your formed elements, or those actual cells. So this is kind of just a different, I believe this is in Desjardins, kind of showing up the breakup of the blood and how they kind of spin it out, and you can see where the formed elements kind of settle to the bottom, and then the plasma, and then the breakup of each one of them. So then we look at the leukocytes, which are all your different white cells, how your platelets make up 140 to 340,000, and then so these are what number per cubic millimeter, and then your erythrocytes make up the 4.2 to 6.2 millimeters. And then on the top there we look at our other solutes of our ions, nutrients, waste products, gases, and regulatory substances. That's about the 2%. And then the water, or the plasma rather, most of it is water. 91% of your plasma is actually water. And then you have the proteins in our 7%. So we'll talk about those a little bit more in detail as we go through here this PowerPoint. All right, so actually, I always do this. I forget to, and I can't go back on these crazy slides. So you have your, hopefully you are printing these out. I would highly recommend that you print them out. I mean, you don't have to print out one slide per sheet. If you want to do like 3 or 4, I recommend that. You know, take your little notes or whatever. But let me kind of go back, because I did have some extra notes here now that I'm looking at my paper written down. So I wanted just to say, okay, again, I did mention that your leukocytes are your white blood cells. So then when you look at the protein at the top of that diagram, so basically this helps, the albumin helps maintain, and that makes up most of the protein. So 57% rather of your protein is the albumin, so 57%, and that helps maintain intravascular colloid osmotic pressure. So it kind of helps making sure that your, how do I want to explain it? So it kind of makes making sure you have blood pressure, basically. So how I was trying to explain that, so the albumin helps kind of keep fluid into your bloodstream so it doesn't leak into the other tissues. So that's kind of maintaining that intravascular colloid osmotic pressure. So sometimes people's, they get third spacing going on where they'll have fluid, but it kind of goes interstitial spaces, so they get really puffy and edematous, like their eyes can get kind of puffy, and then at some of their IV sites or any place where you've had to poke a hole in them, they kind of weep. So those people's albumin levels are usually out of whack, and so they can actually give albumin if they need to. So that's what I was trying to refer to about that. Also your globulins, that's part of your proteins, is the antibodies, where your antibodies are found, and then your fibrogen and your prothrombin, that 4% and then 1%, that's what helps clot your blood. Okay, so your plasma is kind of like that. It does not have the formed elements, and it's kind of a pale yellow fluid, and it consists of about 91% water. Let's see if these numbers, yeah. match up. 91% water, then 7% are these proteins that I just talked about, the albumin, the globulin, the fibrogen, and the prothrombin. So, and you'll find, so that picture that I was referring to on the page that I'm still talking about, but it's not on the slide currently, is 209, so in Desjardins. And it does a nice job of kind of a breakdown of all that. Okay? All right. So again, kind of going over basically is kind of what I just said. You also have this 10% of the dissolved substances, which of those 10%, it's food and salts. About 3% oxygen is carried in the plasma, and about 5% of CO2 is carried in the plasma. Most abundant solutes dissolved in the plasma are called our plasma proteins, which I just went over. Okay, so that albumin, globulin, fibrogen, and prothrombin. So again, albumin helps maintain that colloid osmotic pressure, so you don't third space or lose fluid that way, because somebody can have like a low blood pressure but they still look really puffy. That's because all their fluid is kind of in that third space, so it's really not helping support their blood pressure. And then again, the globulins are part of your antibodies, or help form your antibodies, and then your fibrinogen, and your prothrombin help form clots. Alright, so your serum then is basically your plasma minus the clotting factors. So plasma is, or serum rather, is plasma minus the fibrinogen, and the prothrombin, and the proteins, and that will equal then your serum. Okay, so serum is basically your plasma minus the clotting factors and proteins, and serum is what liquid is remaining after the whole blood clots. Okay, so you can kind of see here the clotted blood settling down at the bottom of the tube, and then the serum. So the serum is kind of what weeps too out of you, like when you have like a scab or something. So after everything's clotted out, it might kind of like have that liquidy kind of, after you kind of get a scab, sometimes you get kind of like that liquid. That's the serum. And they actually serum contains antibodies. So that is your fill in the blank there for that slide. Alright, so now we take a look at red blood cells, or erythrocytes. It's another name for them. They are kind of known for their cool little biconcave shape, as you can kind of see here in this picture. What the biconcave shape kind of allows it to have a increased surface area, which then helps enhance the movement of gases into and out of the red blood cells. Okay, so that's some of the characteristics of red blood cells. They are tough and flexible. They have a tough and flexible plasma membrane, which deforms easily, allowing the red blood cells to pass through small diameter capillaries. They do not have a nucleus. Absence of a nucleus and cytoplasmic organelles limits then their lifespan to only about 120 days. Okay, so your fill in the blank there is your absence of nucleus, and the lifespan is about 120 days. But it provides more cellular space for iron containing hemoglobin. So let me see, because I added some notes here to this thing. I'm going to look at the slide, because all my notes I wrote down are actually on the slide now. So again, the primary function then of the red blood cell is to transport oxygen from the lungs to the tissues, and then to help carry the CO2 from the tissues back to the lungs. Okay, so that's the hemoglobin. Okay, the hemoglobin part of the red blood cells. Okay, Red blood cells are produced in the red bone marrow, in the spongy bone of the cranium, the bodies of the vertebrae, ribs, sternum, humerus, and femurus. Okay, so that's where your red blood cells are produced. So you have the hemoglobin is within the red blood cell. So that statement can be before, so it's not confusing. So the primary function of the red blood cells is to transport oxygen, which is carried then by the hemoglobin molecule. Okay. And your normal range for red blood cells is, I believe it was on that other slide too, it's like 4.2 to 6.2 million per each millimeter of blood, or millimeter cubed, millimeter to the third power. Yeah, 4.2 to 6.2. Yeah, that was on that one picture. Okay. All right. So, because the hemoglobin is basically is made. I mean, your red blood cell is made up of the hemoglobin. Okay. Hope that makes sense. It's kind of within it, part of the substance of it. All right. So again, red blood cells are kind of named according to their size. You might hear them called normocytes, microcytes, macrocytes. Obviously, micro meaning small, macro meaning large. And they're also named according to how much hemoglobin they have within the cell. Okay, so a normochromic means obviously the normal amount. A hypochromic red blood cell would have a lower hemoglobin count, and so it would be more pale in color. Okay, so it'd be, as you can see in the picture there, small pale red cells. So those would be microcyte, probably hypochromic microcytes basically. So they're small and they're pale, where the normal ones have a little bit darker color. And then your hyperchromic would really have an intense color. And a hyperchromic is extremely rare, so you're not going to see that as much as you would see hypochromic. So we're going to talk a little bit here about the hemoglobin in the hematocrit. Okay, so hematocrit basically measures, it's always in a percent. So remember, hematocrit's always in a percent. So basically measures the volume of red blood cells compared to total blood volume. Okay, so a hematocrit, a normal hematocrit for a male is about 45%, and for a female is 42%. So I just kind of want to say a little bit about that, so maybe will help make a little more sense. Hold on one second. All right, so when I was talking about percentage then of the total blood volume, when you think about a hematocrit level being higher, sometimes you'll see that in a patient that's dehydrated, okay, because their total blood volume is less. Their plasma is probably a lot less because it's mainly made up of water. But another thing that you would see is if somebody lives at a higher elevation, because there's less oxygen available. Now remember, it's still 21%. Okay, there's 21% oxygen here, and there's 21% oxygen at the top of Mount Everest. But the barometric pressure is lower, so when you do the math, when you multiply the barometric pressure by the FiO2, you're going to get a lower number. So you have a lower amount of oxygen available. How do I say it? Based on the barometric pressure. Okay, so when you calculate it out, there's less pressure, so there's less availability. So when you think of the hyperbaric chamber, you have increased pressure, so there's increased diffusion going on. That's able to absorb more. It's more concentrated, but the fraction of inspired oxygen, the FiO2, is the same. Okay, but if there's less pressure outside the body, you're going to have less that's going to be able to get dissolved. So anyway, these people that live at higher elevations, then they will often have a higher hematocrit, and you can actually see it when you draw their blood gases. So that's part of our job, is to draw blood gases, generally from the radial artery. And I would see it more so when I worked at Lutheran. People would come down to the lab, to the outpatient lab, and they might, need labs drawn, and they live, up in Idaho Springs or, higher up, like 8,000 feet. And sometimes they were smokers too. Sometimes smokers will have a little bit higher crit. And anyway, you draw their blood, and it was like thicker. It was actually visibly thicker. It would come up in the tube, in the syringe, slower, and you could just see that it was visibly thicker. So their hematocrits then were higher, so they had thicker blood. Okay. All right, I'll stop going on and on about that, but I always found that kind of fascinating. Never really experienced that at sea level when I lived in Wisconsin. So again, then your hemoglobin then is the protein contained in the red blood cell. Okay, so your hemoglobin is the protein contained in the red blood cell that's responsible for delivering the oxygen to the tissues and then taking the CO2 from the tissues back to the lungs. Okay, so hemoglobin is the major substance of red blood cell, of the red blood cells, which occupies about 1/3 of the cell's volume, and that's what gives it its red color. And it is measured as a weight per 100 mils, so it's like grams per deciliter. Okay, so a normal hemoglobin level then, so you're going to need to know these numbers, is 14 to 18 grams per deciliter for a male, and female is 12 to 16. So, and those values are always a little bit higher in men than they are women. Red blood cell count, this is kind of the average, and I mentioned that before, but if you really kind of break it down, the men are like 4.7 to 6.1, and then the female is like 4.2 to 5.4. Okay, so this is all also in Desjardins on page 210. All right, white blood cells. So when you think of white blood cells, so when you think of red blood cells, think about oxygenation, I guess. It's kind of like the correlation. Red blood cells, oxygenation. White blood cells, I always think about infection. Okay, those are my, my soldiers, basically my infection and fighters. So their general function then is to protect the body from microorganisms by phagocytosis or by forming antibodies. Okay, and you have a normal range of about 5 to 10,000 per millimeter cubed, and you'll just hear a lot of times, like in the hospital or during rounds or whatever, they'll say, yeah, well, their white count is 15. They don't mean just 15, it's 15,000. Okay, but we get kind of lazy and we abbreviate a whole bunch of stuff. So just so you know, if they say that their white count was 15, or if their white count was 20, or if their white count was 30, they mean 1,000. Okay, so 5 to 10 is considered normal. 30,000, 25,000 white count would be quite elevated, and that would be an indication of an infection. And then they do a thing called a differential with the white count. So then they're actually able to kind of break down and look at which cell, what type of cell is actually elevated by the differential. We'll talk about that here coming up. So it's just part of the CBC, or the part of the complete blood count is what that stands for, CBC. So I want you to know the terms of leukopenia. Leukopenia then is a decrease in your white blood cell count. So if you had a white blood cell count of like 3,000, you would be experiencing leukopenia. Okay, leukocytosis then is an increase in your white blood cell count. Okay, so know those terms. And then this is actually something that I remember, this term was on the True and False, this diabetes. Okay, So white blood cells are actually able to leave the blood vessels when needed for inflammatory or immune responses. And this ability to leave is diabetes is activated by chemical signals that released by the damaged cells. Okay, so the chemical signals are released by the damaged cells, and diabetes then is this movement of the blood cells. Okay, and I'm trying to think. Yeah, I'm pretty sure it's in Desjardins, if I remember correctly, is where I found that. So let me look really quick and put you on pause for a moment. Yes, so diabetes is defined on page 211 in Desjardins. And hint, it is one of your problems for your true-false homework. All right, moving on to formed elements here. I'm going to try not to spend too much time on each slide, but you know me, I love to talk. So, all right, so let's see. White blood cells, we're still talking about them, the leukocytes, granular leukocytes, okay? And why they are called granular, because I wanted to know what did that mean exactly. Versus non-granular or agranulocytes. It has to do with the staining characteristic. So when you have a granular leukocyte, it's going to like stain either red or purplish blue, just depending on how, when they look at them underneath the slide. Okay, so your granular leukocytes then will stain, and we have the neutrophils. They're the most common type, the most numerous type of phagocytosis. So your neutrophils are going to increase with a bacterial infection. Okay, your eosinophils. So the phagocytosis is kind of like when they kind of surround the cell and, or the infection kind of destroy it. So your neutrophils then take care of the bacterial infections. Your eosinophils, think of eosinophils with asthma, okay? They are active against parasites and parasitic worms. They're also involved in allergic reactions. You're going to have a higher eosinophil count during an asthmatic episodes. And eosinophils are in the tissue lining of respiratory and digestive tracts. But your counts go up with that differentiated white blood cell. You'll see an increased amount of those during an asthmatic episode. Your basophils then are related to your mast cells. They are the least numerous, and they secrete histamines. So they're kind of responsible for causing that inflammation, and they also secrete heparin, which inhibits clotting. Okay, so just know all the differences here of these different cells. As we continue on, now we're going to be talking about the non-granular or agranulocytes. Those are the ones that don't stain, and those are the lymphocytes and then your monocytes. Okay, so the lymphocytes break down into two different types. You have your T cells and your B cells. So your T lymphocytes function in the immune response by acting directly against the virus-infected cells and tumors, and then your B lymphocytes, so maybe think B antibodies, they produce antibodies. So your B lymphocytes or your B cells produce antibodies that work to inactivate these invading antigens that are going on. And then your monocytes are your largest phagocyte. They're capable of actually engulfing the bacteria and cancer cells, and you'll see an increased number of those with chronic infections. Okay, so infections that maybe like a bronchitis possibly, or bronchiectasis, where people have a kind of a chronic infection. They'll have an increased monocyte count. All right, so this is another way of looking at them, kind of just breaking them down into their different categories, and this is out of your textbook. I think, I'm trying to remember if it appears exactly like this, or it's really similar. It's similar. It's on page 214. You'll have something very, very similar to this. Not exactly, but similar. So one of the ways to kind of remember all these different things is, if you look at the first letter, one of that little acronym things, is never eat bananas like monkeys. Okay, so never eat bananas like monkeys. You may have already heard that possibly from Nicole. So neutrophils, never; eosinophils, eat; bananas, basophils. Like monkeys, kind of flipped around. You got the lymphocytes, but then your M for your monkeys, for the monocytes. Okay, so you can kind of see the differences here as far as how long their lifespan is in the blood and what their primary function is. I would just add a little side note for the eosinophil one, is that it increased in asthmatics, okay, during an asthmatic episode for the eosinophils. Okay. And then I also, for the T lymphocytes, next to that cellular immune response, I would write directly attack microbes. So they directly attack microbes, the T lymphocytes. All right, now talking a little bit more about, going back to the platelets. So your formed elements then, so we talked about red blood cells, white blood cells, and now we're going to talk about the platelets. Okay, so when you think of platelets, you just think of blood clotting. Okay, so again, a normal platelet count is 150,000 to 450,000. You are going to hear that broken down to like, you know, they had a platelet count of 100. It doesn't mean just 100, it means 100,000. Okay, so we really get concerned when we have a low platelet count. And a low platelet count then, and I'm not sure if I typed it in the next slide or not, but I want to tell you, is called thrombocytopenia. Okay, so low platelet count is thrombocytopenia. All right, so moving on here with platelets again, so you want to know that thrombocytopenia then is a low platelet count. All right, so blood clotting. So this is kind of talking about really how this process happens. So if there's damage then to the blood vessels, it causes the platelets then to form a platelet plug. The platelets get sticky and they start to, form a little plug. So then as the platelets continue to accumulate, they release an additional clotting factor that kind of enters this clotting mechanism. So it kind of, basically the platelets just kind of start becoming a part of the clot themselves. It just kind of like cascades basically. So there's a little mechanism. So you have damage then to the tissue, release clotting factors then that release, that lead to the formation of the prothrombin activator. So the clotting factors combine with the platelets produce this prothrombin activator, and then the prothrombin activation and calcium then help convert the prothrombin to thrombin, and then the thrombin reacts with the fibrogen to form fibrin, and then the fibrin threads then form like this little tangle to help trap the red blood cells and other formed elements that actually produce the blood clot or a scab. Is basically, it's kind of like one activates the other to the other, and then eventually you have that scab. So there's different factors that can actually alter blood clotting, and I think it's kind of interesting. So the application then of gauze or any type of rough surface to a wound actually causes platelet aggregation and release of clotting factors. So those are something that's going to actually make it clot. And then if you administer vitamin K, that's also going to increase the synthesis of prothrombin. So those are things that are going to help it clot. Things that are going to inhibit the clot are Coumadin, because that's going to delay clotting by inhibiting that prothrombin synthesis. Heparin actually then also delays clotting by inhibiting the conversion of prothrombin to thrombin. And then TPA, which is tissue plasminogen activator, is a drug that's used to actually help dissolve clots, as a clot buster, basically. So you will have people that are on Coumadin all the time. For example, or low doses if they are in the hospital for a while. Sometimes, or like AFib, if you have that atrial fibrillation where your atria just quiver and they're not pumping the blood, your blood is more apt to clot as it's sitting there in the atria, not moving. And sometimes those people are on low doses of Coumadin. And then of course they have to, check their clotting. They have to check their platelet count to make sure that they're not too much. I forget the word I'm looking for, but shoot. Anyway, I'll think of it. So that they're not too anticoagulated. That's what I want to say, anticoagulated. So you want them still to be able to form a clot, like if they get cut or something. And then heparin is given, sometimes it's given IV if you have pulmonary embolism or you have many blood clots in your lungs. You'll be on a heparin drip. Sometimes little doses of heparin, like that's generally another medication that they'll give with like a little shot. I'll think of it here in a second. So you don't get blood clots while you're laying in bed. If you're in the hospital for a while and you're on bed rest, you're not able to move, so your blood doesn't clot. And then TPA is usually given for like a heart attack. If you know for sure, there's a clogged vessel, they might administer TPA, or it's also given for strokes. If you know for sure they haven't had a bleed in their head, so you're taking a CAT scan and there's no bleed, an active bleeding, like an aneurysm, they'll administer TPA because then it's the other cause is a blood clot in the brain. Lovenox, that's the medicine that they give you, Lovenox. I looked up really quick. I knew it. I was like, I think it starts with an L. Anyway, they'll give you a little injection sometimes in your tummy so that you don't get blood clots. All right. So some other disorders that might happen then with these different, so we talked about platelets, now we're moving on disorders of these different formed elements. Okay, and one of them is, there's actually several red blood cell disorders, but one of them can be polycythemia. So that's kind of what I was talking about, but we're going to differentiate that between primary and secondary. But basically, polycythemia as in definition, poly meaning many, cythemia, red blood cells. Okay, there's an overproduction of red blood cells. So that's called polycythemia. Okay, and then on the other side of that, if you have low oxygen carrying capacity of blood, then you can have anemia. Okay, so we'll talk a little bit more in detail here coming up. So when we're looking at primary polycythemia, that's not as common. It's more of a cancerous of the red bone marrow, basically, is generally what primary polycythemia is caused by, is from the red bone marrow cancer. So some of the signs and symptoms again would be that increased viscosity or thickness of the blood. So your blood's going to flow slow. You may have problems coagulating. Sometimes they give people then aspirin then to thin the blood. Okay, so then that's going to lead you to have frequent hemorrhages. Okay, so they use that as kind of part of the treatment of this bone marrow, is to treat with aspirin to help thin the blood. Also, you may have distension of blood vessels or hypertension. That could be another sign or symptom of primary polycythemia. The one that we're probably a little bit more concerned with and that we deal with more is secondary polycythemia. And that was the one I was referring to when I was talking about being chronically low in your oxygen levels. Okay, so it helps kind of offset the low ability, the chronic low oxygen level. So whether it's low oxygen level that's available due to where you live, or if it's, you know, possibly a disease, well, like COPD mainly would be one. Smokers often have a low oxygen level, and so your body compensates by producing more red blood cells. Okay, so then they have that polycythemia, and that's where you will see the increase, that thickness of the blood. So as far as numbers, so they generally have an elevated crit, hematocrit, we often just call it crit, or hemoglobin. Okay, so their crit would be greater than 52% for a male would be considered polycythemic, or greater than 48% for a woman. And then for as far as hemoglobin levels, it would be that should be really the deciliter thing, but it's just another, it depends what source you get some of these numbers from, and they all vary. So don't get too terribly hung up on reference ranges. We talk about normals, but I like the word reference range because some people's normals, that's just their normal, and it might not necessarily be textbook reference range. But anyway, so greater than 18.5 for a male, and greater than 16.5 for a female if you're looking at hemoglobin. But it's generally their crit level that they kind of look at. All right, and so anemia, for some reason there's a low number or abnormal amount of red blood cells. Okay, so actually the percentage is the grams per 100 mils, which is really percent if you think back at it, but anyway, grams percent. So you'd have a low, you know, why are they having a low red blood cell amount? So they either have, again, low abnormal red blood cells, or they have low or defective types of hemoglobin. Okay, so your hemoglobin level for normal is about 12 to 14 grams per 100 mils. And a level of 9 is actually considered anemic. Okay, and some of the different signs of anemia that a person might present with are fatigue, they're tired, weak, they may have a headache, they're obviously pale, and so your body's compensating by increasing your heart rate and your respiratory rate. Okay, so what it looks like under like a slide as far as polycythemia and anemia, well, there's a pretty clear difference here. Polycythemia there being on the left, where there's many red blood cells, too many, and then anemic on the other side where there's not enough. And then anemia itself has different types. You have hemorrhagic, aplastic anemia, deficiency anemia, and hemolytic anemia. So we'll just talk about each one of those on the next coming up slides here. I'm trying to keep this under an hour. Let's see here how we do. So obviously this is hemorrhagic anemia. So it's a very acute condition, something that's happened. It's generally like a trauma or big surgery or a big huge bleed, an ulcer, maybe even a cancer where you're having this acute blood loss. So obviously they're having a difficulty time oxygenating because of the low count, but they also probably don't have much of a blood pressure because they've lost a lot of blood. Really quick, interesting story, or scary story rather, not so much interesting, but scary for my family. My sister, oh shoot, darn it, I touched the screen. Anyway, I just went to the next slide, but I'm talking about hemorrhagic anemia. So she ended up having an ulcer that was bleeding, and she didn't feel good for a few days, kind of just felt weak and tired and that, and she ended up passing out in the restroom her husband found her. She'd been vomiting up tons of blood, and then it came from the other end, and they went in with a scope, and they found that she had this huge bleeding ulcer. So, but I mean, she was at one point almost unconscious. They had to like med flight her. This is back in Wisconsin. A few months ago, they actually had to fly her from a smaller community hospital to Madison because she lost so much blood, and she was like really super pale and scary stuff. But she's doing better now. They're able to figure out where the bleed came from. But I mean, it can just happen that fast. So, all right, aplastic anemia. That is the inability of the bone marrow to produce red blood cells. So that can be caused by chemicals, possible toxic chemicals, irradiation, certain types of drugs. You are generally going to treat this with a bone marrow transplant. Okay, that's the most successful way of treating it. Otherwise, if it is not treated, the death rate is about 70% for aplastic anemia, with about a 3 to 4 month prognosis after you're diagnosed. You only have about 3 to 4 months to live if you can't get a bone marrow transplant. All right, deficiency anemia, caused by an inadequate supply of some substance that's needed for red blood cell or hemoglobin production. So this could be deficiencies, could include, so this is almost kind of like another category with a subcategory of pernicious anemia, iron deficiency anemia, and folate deficiency anemia. So deficiency, obviously you're deficient in something and you're not able to produce red blood cells or hemoglobin. So the pernicious anemia can actually be caused by a vitamin B12 deficiency. So as far as how much, and you're probably wondering like, how much do I really need to know about all this stuff? Just to be able to differentiate, I guess, the differences in the different types of anemia, or kind of recognize. Yeah, I'm just looking at your MRE. So definitely, I'm going to put an announcement. You better look at your lecture before you take your MRE. Yes, sirree. Yeah. Okay. So let's see. So this is generally genetic related. It's an autoimmune disease. It's also, you might have a decrease besides red blood cells, white blood cells, and platelet count. The red blood cells are generally fairly large, so they're macrocytic. The classic symptoms of anemia are coupled, so along with a CNS impairment, so maybe they have some confusion going on with it. So treatment then is repeated vitamin B12 injections. So it looks like, again, there's some type of absorption, inefficient absorption of vitamin B12 in the gut, which then can lead to this pernicious anemia. And so the B12 helps, getting the supplement or getting the injections helps to hopefully alleviate the deficiency. Iron deficiency, this is the most important component of hemoglobin, where you cannot produce hemoglobin if you don't have it. Okay, so iron is the most important component of hemoglobin. You can't produce hemoglobin without it. So this is caused by a deficiency or an inability to absorb iron, which is needed for hemoglobin synthesis. So in this case, your red blood cells are going to be small and pale, your crit's going to be dropped, and so your treatment then is administration of iron. So iron deficiency anemia, that's pretty, kind of explains it itself there. Folate deficiency, I mean pretty much all these do except for pernicious, unless you know what that really means, B12. Folate deficiency then is folate, or known as folic acid, is also necessary for red blood cell formation and growth. In this you're going to see where your red blood cells are bigger. Some medications such as Dilatin which is usually given for seizures, can interfere with absorption of this vitamin. Folate is not stored in the body in large amounts, and it's a continual dietary supplement of this vitamin that is needed. So this is seen more so in pregnant women and chronic alcoholics. So they may have a folate deficiency anemia. So you basically need to figure out what is causing the anemia so that you can correct it so it doesn't affect your hemoglobin or your red blood cell count. All right. This again is just kind of showing how folate adds in the production then of your red blood cells. It works with B12 and vitamin C to help the body digest and utilize different proteins. So just the importance of folate. So we're not done with the anemias yet, guys. So hang on in there. All right. So hemolytic anemia. So when you think of the word lytic, or that ending, so hemo, obviously blood, lytic is like lysis, so it's like destruction. Okay, so lytic, something is like breaking down or destruction. So caused by then a decreased red blood cell lifespan, which caused by an increased red blood cell rate of destruction. So you're having a shorter lifespan for some reason of your red blood cells. Okay, so they're breaking down, they're being destroyed. And some of the symptoms of this, of hemolytic anemia, you could have jaundice, swelling of your spleen, gallstone formation, tissue and iron deposits. Okay, so that's symptoms related to the retention of red blood cell breakdown products. And this is again kind of a sub thing. We're gonna talk briefly about the sickle cell, the thalassemia, I don't know how I pronounce that, erythroblastosis. All right, so sickle cell, you probably have heard of that one before. It's a genetic disease resulting in the formation of abnormal hemoglobin, primarily in African Americans. The hemoglobin causes the red blood cell to become more of a sickle cell. It's actually the shape of the blood cell. Oh, in fact, I forgot to show the slide. Sorry, I'm looking at my notes. So the red blood cells, instead of having that bioconcave shape, they actually have the sickle shape. Okay, so and they are rigid. So they have, which then results in plugging of small blood vessels. So the hemoglobin causes the red blood cells to become sickle cell anemia and rigid, resulting in plugging of small blood vessels. So this actually can happen. It's something that they screen for, I know, in newborns. And you can kind of see here in this picture what happens, how it kind of plugs off or blocks the blood vessels. So this occurs in about 1 of every 600 African Americans. So again, it's genetic. Thalassemia is also an inherited hemolytic anemia. Mainly appears in Mediterranean descent. The red blood cells are small and short-lived. It has to, so the parent has to have, if you have one parent, then you may have a mild thalassemia trait. If you have 2 parents, then you may develop a severe thalassemia. And that they have skeletal deformities, swelling of the liver and spleen. Again, the treatment is bone marrow transplant, stem cell transplant for long-term success. Okay, now talking about erythroblastosis. Wait, hold on one second. Erythroblastosis fetalis. This is basically a hemolytic disease of the newborn. I have to just laugh at my mispronunciation. What else can I do? Otherwise I'd probably cry because it's really frustrating, but whatever. So it's hemolytic disease of the newborn. So this basically happens more so with the second baby. So I have some little notes written here. So it happens with the second baby if the mom is Rh negative and the baby is Rh positive. Okay, so the baby that is born has a decreased red blood cells and decreased hemoglobin. They're jaundice, and they can go into DIC, which is disseminated intravascular coagulation. And then their heart and lungs are damaged. So DIC is not a good thing. DIC is something that happens and often results in death. So everything just starts to weep, and you start bleeding into cavities that you're not supposed to bleed into. And not only do they get weepy, and I'm talking more of adult situations that I've seen people go into DIC. So not only do they third space in that, but they actually just kind of start bleeding out from everywhere. It's quite disgusting. So again, there's an incompatibility going on here with the Rh factor is basically what's going on. The maternal antibodies are fighting against the foreign, which is really the fetal red blood cells, or the Rh factor, because it can cross the placenta and enters the fetal circulation and basically destroys the unborn baby's red blood cells. So that's why they can go ahead and give the Rh factor or RhoGAM to Rh negative mothers. So if you're ever pregnant or whatever, they always check to see if you're Rh positive or negative. And if you are Rh negative, especially if it's your second pregnancy, they will give you RhoGAM so that does not happen. And so this is, the first pregnancy is not really recognized. Your body doesn't really recognize it, but then the second one is when it happens. So you can kind of see here with this little diagram here. So it destroys the unborn baby's blood, basically, is what happens. So in the first one, you have the Rh negative mother. Everything's okay. Between pregnancies is when these antibodies develop, and then you have trouble with the second pregnancy. All right, so here is kind of a little summary of all the different ones that we talked about, the red blood cell disorders. So, make sure you're kind of at least, know the major characteristic between each one, what defines them. Now we're moving on to blood typing. All right, so now we're just going to talk a little bit more about blood and about blood typing. So about 41% of Americans are type A blood, type B 11%, type AB then is 4%, and they're considered the universal recipient. Okay, they do not contain any anti-A or anti-B antibodies in the plasma, so it's not going to clump with any of the donor's red blood cells containing A or B antigens. So we have antigens in our red blood cells, and then antigens stimulate antibodies. So if it doesn't have those antibodies, it's not going to attack the blood. Okay, so it can accept the AB is the universal recipient. It can receive any type of blood. Okay, so it's not going to clump. It's not going to have a reaction, basically. And then your type O, but it's only 4%, or type AB. And then type O then is your universal donor. Okay, so those people can donate blood, and 45%. That's actually, I didn't realize there was that many. 45% of Americans are type O. Universal donor, they're type O negative. So it's O negative, can be transfused into patients with other blood types. So O negative. So this is kind of like a little chart that sort of helps tell you a little bit. So antibodies are present then. I kind of write plasma kind of to the left of antibodies present. I wrote plasma, and then antigens present is in the red blood cells. Okay, so that's where the antibodies are versus the antigens. And the Rh system kind of works as so if you have an Rh positive, okay, so that means you have the Rh factor antigen is present in the red blood cell. If there's Rh negative, there is no Rh factor present in the red blood cell. So there's no anti-Rh antibodies present naturally in the plasma. Okay, so this is for Rh negative. So I'm going to kind of repeat that then. So for Rh negative, then it is no Rh factor present in red blood cells. So that's like the group O there where it says none. So that's no Rh factor, no antigens present in the red blood cells. And then no anti-Rh antibodies, so an AB, are present naturally in the plasma. Anti-Rh bodies, however, appear in the plasma of an Rh negative person if the Rh positive red blood cells have been introduced into their bodies, like in pregnancy. Okay. All right. Moving on. Okay, so white blood cells, the different disorders, we have two major types. We have cancers, or we have neoplasmas. Okay, so our lymphoid or lymphatic cells, these are neoplasmas that result from B and T lymphocyte precursor cells or their descendant cell types. So when you're talking about lymphoids, you're referring to the lymphatic cells with neoplasmas in the lymphatic cells. When you're talking about myeloids, you're referring to bone marrow. So then you have neoplasmas that result from some type of malignancy going on in the, let's see, neoplasmas that result from malignant transformation of precursor cells of granulocytic white blood cells, monocytes, red blood cells, and platelets. So we're looking at either if it's in the white blood cells are either disorders are either cancers or they're neoplasmas. So just know the neoplasmas for the lymphoids are the lymphatic cells from the B and T cells, and then the myeloids are from your bone marrow cells. And then we also have different types of myelomas or leukemias, and it just depends on which cells. So we have 5 different groups here. We have a multiple myeloma. Okay, multiple myelomas are basically cancers of the B lymphocytes or the plasma cells. So this is characterized by recurrent infections, anemia, destruction and fracture of bones. It's the most deadly blood cancer in people over the age of 65. Is your multiple myeloma. So again, cancer of the B lymphocytes or the plasma cells. And then we have 4 different types of leukemia. So we have CLL, you'll heard it be. So this is again kind of referring back to the lymphatic cells. So you have chronic lymphocytic or lymphatic cell leukemia. It's kind of more of a slow development. Acute ALL, or acute lymphocytic or lymphatic. So these are, again, cancers of the lymphatic cells. And it's more of a rapid development of symptoms. And then your chronic myeloid, again, these are from your bone marrow cells. So again, this is going to be a slower development. And then an acute AML, which is your acute myeloid, again, from your bone marrow leukemias. So just kind of knowing what the difference between acute and chronic. I mean, obviously, usually the acute leukemias, they get more sick, faster, and they end up, it's more of a challenge to treat those patients. Almost done. Well, I went over my hour. I only have a couple slides left. Okay, so again, some other disorders of white blood cells. You've probably heard of mono. It's definitely non-cancerous. Highest incidence between the ages of 15 and 25. It's caused by a virus in the saliva. It's easily transmittable. They present with fever, fatigue, sore throat, rash, enlarged lymph nodes, and your spleen's enlarged, and it can last for about 4 to 6 weeks. So it's kind of like a little kissing disease. Again, fever, fatigue, sore throat, rash, enlarged lymph nodes, enlarged spleen, and generally lasts about 4 to 6 weeks. Another type of disorder can be hemophilia A. It's considered a clotting disorder. It's the most serious bleeding disorder worldwide. It's an X-linked inherited disorder. It results from the inability to produce factor VIII plasma protein responsible for blood clotting. It's characterized by easy bruising, deep muscle hemorrhage, blood in the urine, repeated episodes of bleeding into the joints, causing pain and deformity. So you definitely don't want to give these people any blood thinners or aspirin. Oops. And lastly, thrombocytopenia. So thrombocytopenia, so you think thrombo, you think of clots, cyto cells, penia low. So this is a reduced platelet count, okay? So caused by reduced blood counts, but reduced platelet blood counts, okay? So again, your platelet count here is 20, okay? So what were we, like 150 to 400 before, I think, for your platelets? Thousands, if I remember. So if someone was saying that this person has a platelets are 20, it means 20,000. I'm flipping back to my notes. So it can lead to catastrophic bleeding. Most common cause is the destruction of bone marrow. Yeah, 150,000 to 450,000 is your normal range. So a platelet of 20,000 is quite low. So some of the different causes can be, again, they've gotten some drugs, possibly, or chemical radiation due to cancer, lupus. So it can be kind of like a side effect of a different type of treatment. Or for HIV also, it's characterized by bleeding from small blood vessels. That's, you can really see really well underneath the skin and the mucous membranes. And so a lot of these like little tiny dots here are called petechiae. Petechiae. You might see all this little tiny, sometimes it's not quite as diffuse as these bigger spots, but sometimes it's just all these little tiny dots, and it's called petechiae. With a P, P-E-T-C-H-I something. Not exactly sure on the spelling of that one. All right, I will put an announcement out. You want to make sure you look at this before you take your MRE. Until next time.